are we dealing with myocarditis here? Or toxic effects, because then both ventricles might be affected rather than the left ventricle, which is more coronary dependent. That's the reason why I was asking.
So I couldn't see any significant deterioration of the RV in function. So definitely, if there is something, it has affected only the left ventricle and not the right that much. So the right was small and the function was overall good from what I saw in the limited images from transesophageal echo.
So Chandra, what do you think? The right ventricle doesn't appear to be very affected. So one has to think more about the coronary situation here. Again, since you mentioned coronary spasm, I'd like you to give a little bit more thought. What do you think after this presentation of the echo, Chandra? And then Ty, I'm going to ask you the same question.
The ventricular wall is thick, which could happen in myocarditis also. So it might be good to go back and see if it was thick even before the transplant, or is this thickness because of edema? So that would be one way to look at it. I do not see any regional wall motion abnormalities. So that doesn't fit like a distal LAD STEMI. Myocarditis is still in the differential diagnosis, but I'm leaning more towards something global, ischemia, maybe spasm or something related to that. I don't have a good answer at this stage.
Ty?
And I have a similar view. I mean, this really speaks to a global process. There's no focality to the wall motion abnormalities here. Even going back to the original electrocardiogram, although there was ST segment elevation lead AVR and trying to make an argument that this was an ischemia-driven mechanism, I think you could clearly say that the ECG is reflective of a diffuse hypoperfusion. And the question that I don't know the answer to is this due, and it was not purely a hemodynamic phenomenon early on. Now, certainly that's a contributor given what the person's blood pressure is when this is being assessed. But I have a hard time knowing whether this is a diffuse non-ischemia related mechanism or ischemia is at hand. I know it was mentioned about septic shock. Clinically, one should be able to differentiate, whether the patient's warmer and well perfused or is all clamped down as to whether this is a primary cardiac or secondary phenomenon. But obviously, a concurrent evaluation given the patient's underlying recent transplant status and pancytopenia is going to be important as well.